we now pivot to this. So in a minute, Dr. Pendleton, I'm going to give you the screen so that way we can share your screen. But I want to just tell you a few words about Dr. Pendleton. So in the way of history, she got her BS from New York University and then went on to Johns Hopkins from 2005 to 2006 for a post-bac work in a laboratory 2006 2007 at the medical school, and then stayed there for medical school at Johns Hopkins from 2007 2012. And then you can actually see went on to do a special enfolded fellowships in pediatric spine deformity, and went on to finish her residency in Jefferson, where she started, and then went on to do her peripheral nerve fellowship with Dr. Spinner in Rochester, Minnesota. And then in 2020, she was recruited at Stony Brook as an assistant professor in neurosurgery and to also lead their peripheral nerve spine-focused neurosurgery program. Multiple awards, dating back to several years. You can see the Sherry Apple Resident Travel Scholarship, the Pew Synthes Residence Education, AOA, abstracts left and right, including travel scholarships in her time at Johns Hopkins when she was a medical student. And she actually did a tremendous amount of work, tons of publications, and you'll see already her H index currently, which our teams put together, some publications with our group as well. She actually has already an H index of 11, and according, we do this with all our residents and our faculty. We track their H index over time, and Hugo Guerrero has been in charge of that endeavor, as he's now the vice chair of research in our department. So in terms of just a personal note, Courtney spent time working in our laboratories through a Howard Hughes fellowship at the time when she was a medical student at Hopkins, and she was an absolute pleasure to have in our team. Actually, it was her work that really began the whole set of protocols that we have now with mesenchymal stem cells. She really wrote the very first paper in our laboratory where she compared around 2009, 2010, the very a comparison between mesenchymal stem cells that were derived from fat versus mesenchymal stem cells that were derived from bone marrow, and show that they were comparable and that we can use them similarly for our endeavors to fight brain cancer. And that really led to several federally funded grants in our laboratories and many publications. There's then an innovation, patents, and most recently, several awards, and other people in our group, including plastic surgery, is taking it to the next level, as well as radiation oncology. So really, really, Courtney, your work began a lot of stuff. So I'm going to go ahead and stop this right here, if it's okay with you, and I am going to give you the screen, and so that way you can take it away.
Thank you, Professor.
All right.
Is everybody able to see the screen?
Yes, we see it now, Courtney.
Okay. And are you seeing the presenter view or the regular view?
I think we're seeing your view, your presenter view. Yeah.
I will apologize. How about now?
Now it's good.
Okay, perfect.
Yes, thank you.
Thank you. I appreciate it. So thank you again for the opportunity to come and talk with y'all about something that's really been near and dear to my heart since I was working with Dr. Quinones as a medical student. So Maverick Medicine, which is really how Harvey Cushing built the special field of neurologic surgery. I have nothing to disclose in relation to this particular talk. A little bit of background. So there's been a great deal written about Harvey Cushing and the founding of neurosurgery as a surgical subspecialty. And then back in 2007, when I first started working with Dr. Quinones, we really embarked on this project to find and review Cushing's early surgical records from when he was both a trainee under Halsted and then a new attending at the Johns Hopkins Hospital. The project itself had some very humble beginnings, and I think like most things, opportunity looks like work, and it is very rewarding, but it took a lot to get this project off the ground. So we started by looking at a paper from back in the 1990s written by Dr. Greenblatt, where he attempted to do the same thing we had done, and he looked at Cushing's early research and practices. And his discussion really commented that the archival materials at Hopkins seemed incomplete in many ways, that the operating room logbooks that he had access to were missing information, did not correlate with the records themselves, which are on microfilm. And then looking at the microfilm, things were really deteriorated, not easy to read, and patient records that should have been there were missing. So we started this project at a little bit of a few steps behind where we would have liked to have been. And I think one of the things I learned from this project was really why being nice goes a long way. We started by being given a box of maybe 6 or 7 reels of microfilm and told this was everything the archive had. And I spent many, many evenings in the basement of the Phipps building in medical records, where the only microfilm reader was in the institution, and got to be friends with the folks in medical records. And near the end of this, one of the women said to me, she said, "You seem very disappointed." And I said, "Well, yes, there should have been a lot more information, and I'm disappointed that we didn't have more microfilm." And she said, "Oh, they're in the broom closet." So really just serendipity. If I hadn't had that conversation, if she hadn't been there that morning, if she hadn't been working there for 30 plus years, we might never have had this project. And so I think it was just a nice reminder that being kind and being engaged with the people around you goes a long way, and can really have a tremendous payoff, which it has over the past decade. So a brief biography of Harvey Cushing, not to belabor the point, was born in 1869 in Cleveland, Ohio, went on to Yale University for his undergraduate studies, where he played baseball, much to his father's chagrin, went on to medical school at Harvard, his intern year at MGH, and then surgical residency at Johns Hopkins under William Halsted. Following his residency from 1900 to 1901, he did something that was fairly common for folks of his education and financial economic background, which was this thing called a Wanderjahr, which is sort of a focused wandering year of gaining additional experience and information to sort of guide your career choices. So he traveled throughout Europe, worked specifically with Theodore Coker and Byrne doing some ICP experiments. This comes into play later in that Coker did a lot of glandular transplantation experiments with the thyroid and parathyroid. Cushing worked with Charles Sherrington out in Oxford doing brain mapping in primates, and then worked through Italy looking at observation of blood pressure monitoring. And he then brought this device back to the United States and really introduced intraoperative blood pressure monitoring and documentation into the surgical record. In terms of practice building, how he went and built the special field of neurologic surgery, Dr. Quinones had told me this when I first started working with him, that there are really 3 things that gain you success in any field. And those are affability, availability, and accountability, sort of above all else. And Cushing really embodies these in how he goes about creating a practice. First, opportunities and serendipity. Much like the project that Dr. Quinones and I had worked on, Cushing himself had some opportunities and serendipity at play. Going through some of the Yale records, we found this documentation that, truthfully, he hadn't wanted to be a surgeon to begin with. He'd wanted to be a medical doctor and study under Osler at Hopkins, but Osler didn't have any spots. And so he asked Dr. Halsted instead as a second option, who also didn't have any spots. So Cushing went on vacation with his family and got a letter when he got to Minnesota that said Dr. Halsted, in fact, did have a position, but he had to come right away. And so Cushing drops everything, leaves his family vacation, moves to Baltimore, and takes what was, in fact, his second choice of a surgical residency spot with William Halsted. So, but for Dr. Osler not having a position available or Dr. Halsted's letter not reaching him in time, we might be having a very different conversation about the field of neurosurgery and Harvey Cushing's role in it. Mentorship, which is really integral to any academic endeavor, any endeavor really. His primary mentor was William Stewart Halsted, and Halsted was known for pioneering the surgical residency structure here in the States. He really was dedicated to developing a meticulous operative technique in terms of sterility, and then also hemostasis. And these are skills that Cushing then used to create neurosurgery as a viable and survivable surgical specialty. One of the things that I found very interesting was all the old operative records document whether or not gloves were used in operative cases and then the outcomes for those patients. And one of my favorite sort of medical history tidbits is that we don't wear surgical gloves, or we didn't start wearing surgical gloves because of infection or because touching the operative field with bare hands was gross or disgusting. We started because William Halstead's scrub nurse had a very bad contact dermatitis from the dilute carbolic acid that was used to cleanse hands and instruments. And she was going to quit. She was going to go do something else because she couldn't bear the contact dermatitis. And Halstead quite liked her. He thought she was very efficient, and also liked her as a human. So he commissioned the Goodyear company to create rubber gloves for her. And she ended up staying on. They ended up getting married. And he ended up sort of retrospectively looking at these records and discovering that not only did they keep him his scrub nurse, they also kept infections down. And so that was something that was propagated through Hopkins surgical practices. Unfortunately, while he was a fascinating, very innovative individual, he was often absent because he had very heavy cocaine and morphine addictions, which he developed while he was experimenting with cocaine as a local anesthetic, using himself as a test subject. Cushing still had a very productive relationship with him and thought very fondly and kindly of him. This is an illustration from the archives that Cushing had done of Halstead. But he needed another mentor, and William Osler really rose to the occasion. He had great interest in neurology, by extension became a very strong advocate for Cushing to pursue neurologic surgery. He was very steadily present through Cushing's training and providing a connection to the neurology clinic, which served as a major source of referrals for Cushing until about 1905, so the first half decade of his practice as a neurosurgeon. Cushing may also have been one of the few, if only, neurosurgery attendings who voluntarily staffed a neurology clinic every morning as a junior neurosurgical attending. So affability and availability certainly come into play there. And then Osler became a lifelong friend and mentor to Cushing. Cushing actually went on to win the Pulitzer Prize in biography in 1926 for a 2-volume work on the life of Sir William Osler, which is an excellent, if very dense and very thorough read. Early cases. So again, getting to availability and in some ways affability. Cushing's first recorded case as a surgical trainee, he was very excited about this when he wrote his note, was a ingrown left toenail. So no case too small and nothing that you cannot learn from. And proving that some things don't change across years and years of time, his first recorded case as an attending was a revision decompression for suboccipital neuralgia. So the willingness to do the less interesting cases perhaps really helps build rapport and a referral base. And then most importantly, catchment area. How do you build a catchment area? How do you bring patients in when you are arguably the only person doing what you're doing and you're really developing the field as well as your referral base? So to answer that question, we looked at the surgical records for the elective neurosurgical patients from 1900 to 1912 and looked at the geographic data, so hometowns for all of these patients. In total, that was 655 patients of the records we had. And we used sort of a freely available online mapping service to calculate the distance traveled from the patient's hometown to the geographic center of Baltimore. Average distance was about 379 miles. And the range obviously was quite broad, anywhere from 1.4, which was the distance within Baltimore itself, to over 8,000 miles, which was a patient who traveled from the Philippines multiple times to see him for operation on a brain tumor. This is just a map representing sort of where his patients came from. Clearly very heavy in the sort of northeastern seaboard, obviously quite heavy in Maryland and Baltimore in particular, but ranging all the way out west to California and Oregon. And then not on the US map, obviously, would be his international patients, including folks who came from Canada, folks who came as far away as from the Philippines, and a few patients who, although they had home ties to the northeastern seaboard, were actually living abroad in the UK when they came to seek his care. One of the ways that this was enabled was the railroads. So this is a map from 1890, and the railroads expanded and expanded through the early 1900s. So obviously a large cluster of railway connections from the Midwest out east, and then some from California, Washington, Oregon. And you can see in the patient charts that many of the patients who were coming from further west were working for the railroad or living in cities that were on the railroad line. So certainly the availability of transportation helped Cushing build a catchment area that truly was the entire nation. And then communication, always essential. This is the paper that Dr. Quinones and I had published in the Pharos looking at Harvey Cushing and the patient-physician relationship through written communication. And many of these patients, especially those coming from further away, weren't going to come back for their 6-month follow-up or their 1-year follow-up. They wrote letters. So postoperative follow-up really was used, written communication very heavily. Patients and families would notify Cushing of the death of some of his patients. One of the most stunning use of written communication was gratitude. Many patients wrote Cushing letters thanking him for his efforts, whether or not they were successful. Families wrote letters of gratitude, even for patients who had passed away. Miscellaneous requests, a little bit of a cult of celebrity. A few patients wrote Cushing repeatedly asking for signed portraits of himself, which he appears to have never sent. And then referrals. Patients would write letters saying, oh, this friend of mine, this family member of mine, this neighbor of mine has a neurologic complaint. Can you see them? Unfortunately, most of these letters didn't include the name or obviously a hospital number for the patients. And so matching the referral letters to patients in the records has really proved a more difficult task than I might have liked. But he did get referrals through communication with his patients. This is just an example of a patient who had an MCA thrombosis that Cushing did a exploratory craniotomy, expansion duroplasty, osteoplastic bone flap, who did well and wrote later thanking him very much for sort of restoring his life to him. And now sort of my favorite part of the talk, the Maverick Medicine part. Cushing was remarkably innovative. He commented related to hydrocephalus and CSF diversion with this, but I think it is worth reflecting on that as we look back over 100 years, that many things that we do and consider commonplace and easy now were at one point novel. And so any of the neurosurgical procedures Cushing was working to develop and create sort of survivable operative procedures from were novel for him. And we need to sort of view a lot of his work in that context. Extraordinary measures. This is sort of a favorite project of mine. We had looked anecdotally that many patients seem to have some very extraordinary things being done to them in order to keep them alive so that Cushing could operate and take out their brain tumors or decompress them or do more exploratory surgeries to try to find an etiology for their symptoms. So we went back and sort of created a database of this and found that 22 patients had some form of extraordinary measures employed, specifically documented as being done for the preservation of life and the ability to perform additional operative intervention. And this included artificial respiration, placement of tracheostomies, use of transfusions and pharmacologic stimulants, and things like open cardiac massage. So of those 22 patients, you can imagine it skews rather young, 25.8 years on average, fairly broad range. Split between male and female is relatively even. And then one thing that was very interesting, we looked at the ethnicity or race of these patients, which is really broadly documented in the records. Patients were listed as white, Black, immigrant, Bohemian, Czech. It was a little sort of a hodgepodge of terminology used. So we separated this broadly into patients who were Caucasian, patients who were African-American, and then patients who would be sort of non-Canadian and non-British immigrants. And the reason for that was we felt Canadian and English immigrants didn't have necessarily social stigmas against them. And so they may have been lumped in with the Caucasian group in terms of looking at the type of treatment they received. In terms of the extraordinary measures, everything sort of reflects what the overall population of Cushing's patients was. So there wasn't an instance of patients who identified as Caucasian getting more extraordinary measures, nor was there really an incidence of patients who were non-Caucasian being, quote, experimented on, unquote, and having more extraordinary measures performed on them. Of the patients with extraordinary measures, 12 of them had artificial respirations performed intraoperatively. 5 of them required long-term ventilation, which was done manually with a bellows. And that lasted anywhere from 3 to 72 hours, which as a manual labor task is rather extraordinary. Overall patient outcomes, as expected, most of these patients did quite poorly. 18 of them died during the admission. 4 patients were discharged from the hospital, and there was long-term follow-up in 1 of them. This is a patient that Cushing had written up in a unpublished manuscript. 40-year-old woman who came in with these sort of nondescript cerebellar signs. So he took her for an exploratory suboccipital craniotomy where she became apneic and never resumed respirations. So this is part of his typed operative note where he talks about how he stopped operating and started performing artificial respirations through this manual sort of arm and chest compression maneuver that was developed by Schaefer for management of drowning or drowned patients. And for any of the students who, have had bad days at work, this particular student, Mr. Bass, then took over for Dr. Cushing and continued to perform these artificial respirations for 45 minutes while Cushing continued the operation. And what he wrote about later was this idea that in patients with cerebellar pathology who became apneic during surgery, the thought was that this was actually compression of the medulla. And so he had a series of patients where he expanded his bony decompression and manually pulled cerebellum and the tonsils out from the foramen magnum to decompress the medulla and had resumption of spontaneous breathing, which is what happened in this woman here. Interestingly, not only does she start breathing again, she starts moving because they had held off on giving her any more ether. And then before they're done with even the bony decompression, she starts answering questions. So that's an interesting approach to intracranial neurosurgery. Awake suboccipital decompressions. She then is brought back during that admission after surviving that event to have removal of a cystic tumor. Unfortunately, the pathology for that was not readily available in the records. And then she followed up in person and via letters through 1921. We have access to some of this because Cushing had some overlap in what was documented between his different hospital records. And I think this note from 1913 really sums everything up, which is patient walks into the Brigham Hospital in 1913 after having that event in the OR. And she writes letters thanking him for what he's done, that she's doing quite well. And these are some other representative cases of extraordinary measures: artificial respiration and open cardiac massage in a small child with a traumatic injury. As was common, unfortunately, while they got ROSC from open cardiac massage, it was only transient and the patient expired in the operating room. This is the paper that Cushing had written up. We found in the Yale archives. He had never published it. We then pulled the rest of these patients. So this is on the docket of projects to work on in the future. And Cushing comments in the paper on this notion that if you had something more than manual bellows, could you keep these patients alive indefinitely? And then comments on, but is this state to be considered life? Which is this really early discussion of not brain death truthfully, but the moral and ethical quagmires associated with keeping patients alive through these extraordinary measures when there really is not a chance of them waking up and having a functional recovery. Some of my highlights of going through these records: neurotransplantation. Fetal pituitary transplantation was a favorite of ours, I think Dr. Keynote knows. So this 48-year-old gentleman comes in with some headaches and vision changes, undergoes a resection of his pituitary adenoma and develops terrible hypopituitarism. And he comes back with these symptoms, and Cushing says, well, I worked with Theodore Coker. He did glandular transplantation for the thyroid and for the parathyroid. The pituitary is a gland. We could transplant one. So he obtains a pituitary gland from a aborted child and performs a subtemporal craniotomy and just implants this into the cortical matter. No real elegance to that surgery, but certainly conceptually very interesting. He documents that the patient does well. The patient goes home and then comes back in extremis, and the wife begs Cushing to do something. So he says, well, it worked for a little while the first time, we'll do it a second time. And this time finds another, a stillborn child this time, and performs a revision subtemporal craniotomy and implants this gland into the patient, who of course does not do well and ends up passing during that stay. Cushing then writes in his monograph about this patient and has this sort of little bit of a riff on perhaps this was the wrong way to go about it. Perhaps you need to actually be able to grow this tissue in plasma from a prospective host, and that then maybe you would have some kind of tissue matching. And it's notable to think that this is before we had any kind of tissue genetics. This is before even blood types were really commonly used and identified. And he's talking about patient-specific medicine, even though he doesn't quite understand what the reason for this would be. He does understand that if you grew these cells that grew in a patient's blood or plasma, they might be more likely to take, as it were. And then if anyone ever has a chance to come up to New Haven to look at the Yale Cushing Center, as you come into the center, which is underground, this is the patient's brain here. You can't quite see where the pituitary glands are implanted, but that is the patient's brain. And then as a peripheral nerve surgeon, one of my favorites is nerve reconstruction with a rabbit spinal cord. This young woman, 23-year-old woman, comes in with this leg pain, this sensory deficit, and is found to have this large tumor, which it's unclear if this is a soft tissue sarcoma encompassing the sciatic nerve, or if this is truly a malignant peripheral nerve sheath tumor. Regardless, he takes the entire thing out with margins and has this like 15 or 18 centimeter gap. So he understands that he can't just leave the gap there if he wants to try to get her some function back. And he understands he needs something that has some kind of conductive matrix to it, some kind of scaffold. And so he just says, small, I think this says emaciated, rabbit procured. No idea where, no idea how, would have loved to have been that medical student going to find it. And he takes its spinal cord, stem to stern, takes its spinal cord and implants it as a scaffold for peripheral nerve regeneration. Now, unfortunately, this was some sort of malignancy before chemotherapy or really radiotherapy. And so the tumor recurs and she requires a leg amputation. And there was nothing sent for pathology to see if there had actually been nerve regeneration. But conceptually, again, a very interesting thing for him to be pursuing. Cortical and subcortical mapping. So just briefly, this is something that I distinctly remember finding these pictures in the records and just stopping what I was doing. And I think I emailed Dr. Keynote and said, you're never going to believe this. So Cushing had this relationship with Penfield. They were friends, they communicated with each other. And before Penfield defined the homunculus, Cushing was mapping both cortically and subcortically in the brains of patients with epilepsy and tumors. And you see him documenting, there's the leg here, the arms, head, tongue. He wasn't entirely spot on in that, the current stimulators he used had a lot of spread to them, and he struggled to find the leg area coming over into the intrahemispheric fissure. He never quite got the hang of it. And there are some letters between him and Penfield where he describes this and says, I just never quite got it. And so I went on to things I was better at. Ethical quagmires, and this is where we wrap up the talk. So with innovation comes some questions of ethics and morals and what it means to put the needs of the patients first. So this is a 36-year-old man with gigantism. He is actually case 32 in Cushing's pituitary monograph. These are pictures that are slightly similar to, but distinct from the ones that Cushing published that we found in the records. This is his assistant, I believe it's Dr. Crow, to show the relative size of this man to an average sized human. I think Dr. Crow is approaching 6 feet, so you can get a sense of how tall this gentleman is. This is his hand. In the pituitary monograph, there's a fold out of a life-size x-ray of his hand. It's about 2.5 times the size of my own hand. And this is his description of this patient, that the patient came to see him, he didn't have any surgical needs, and so they sent him on his way, and then he died. And they just comment that 3 days later, they obtained permission for an autopsy, and it was conducted under most inauspicious circumstances. Now, you would think this was, the patient was embalmed, it was delayed, but no, in the records, and this handwriting is Dr. Cushing's handwriting. So they found out accidentally, like in the paper, that this man had died. And it's not a violation of his privacy. His name was actually published in the monograph itself, to be clear about that. After considerable negotiation by Dr. Cushing over the telephone, they obtained permission to make an examination for $50. They paid the undertaker $50, And they did it in the undertaker's establishment while the funeral service was going on. So rather inauspicious. And to put that in perspective, when I looked up what like union salaries were in the Baltimore, DC area, undertakers made on average about 50 cents an hour. So they made about $520 a year, depending on how much they worked. And they paid the man $50 to do a unauthorized autopsy.
And Courtney, just
Yes.
this is this was amazing. This one, go back to the prior image, because this is, once again, I just want people to realize these things were not known. Courtney discovered all these things in those micrographs, that she was exploring. And one thing that she forgot is, like, I remember when she came, they didn't have an appropriate micrograph that could read a lot of the stuff. So we had to buy another one to be able to look at all these things. So these things were completely discovered. You can actually see, as as the service was going on, with 3 exclamation points. These are their own writings, actually. So this
Yes.
was absolutely incredible for us to see. These are some of the few papers that I have had in my life published, where we sent the papers and they didn't want any revisions. And we literally had about 50 of these papers. They were so, thirsty for this type of knowledge that people didn't know. So
I think this was our fastest one, Dr. Quinones. I believe we sent this in to pituitary and it got accepted before the end of the business day.
yeah, that's true. It was amazing. The editors, they kept reading Nature, published some of our papers, Cortex. I mean, they just couldn't get enough of this reading. It was just fascinating, as you see a lot of comments. But this was amazing. I see Dr. Sampson right here also from the pituitary disorders, and it was truly, truly amazing. I remember at the time, the trek, if I remember correctly, from Baltimore to Washington, D.C. was not trivial. It was a whole day endeavor to go back and forth.
Yes. As part of the catchment area, I've sort of been looking at the times it takes to get from one place to another via rail. And, we think Baltimore to DC is, you hop on the train, it's an hour and you're there. And it was a full day endeavor. They rushed to get this done. And then they also comment that, of course, the body was in the coffin, so they can't move it because there's still the service going on and no one knows they're doing this. So inauspicious circumstances, I think, indeed, Dr. Quinones.
Yeah.
And then just, things that come up in this, it's funny, it's humorous to read this, but there are very real world contemporary implications. This is survivors from the Tuskegee syphilis experiment, men and women who had syphilis and were denied treatment, but told they were being treated, to watch the natural history of that disease. This is remaining family of Henrietta Lacks, who still reside in East and West Baltimore. Henrietta Lacks obviously is the woman who provided HeLa cells because she had a horrifically aggressive version of cervical cancer, was treated at Hopkins. Her cells were studied and were then commercialized and monetized. And her family, many of whom live in poverty in Baltimore, were unaware of this until a book about this came out a few years ago. And so, although a lot of the stories of what Harvey Cushing did and the sort of Maverick Medicine are humorous and entertaining in retrospect, there are very real implications for how do we talk about ethics when the very nature of his surgical field and some of our surgical fields is novel. How do you define ethics when no one knows what happens next or what might happen? And then all of the stuff with Harvey Cushing and his innovation highlight the need to really support innovation, but also reflect strongly on and think about what that means for informed consent and ethical research conduct, because there's a big gray area. And although Cushing certainly blurred the line, it is well beyond what we are able to do today for good reason. And I think it really highlights conversations we need to have as contemporary physicians and surgeons. And then acknowledgements. The Allen Mason Chesney Archives at Hopkins and the Cushing Whitney Medical Library at Yale provided access to and reproductions of all of these records for us. As a medical student, many moons ago, I had funding from both the Osler Society and the Fenric Research Travel Grant. Apologies to his last name. And then, of course, many thanks to Dr. Quinones, who really supported this project over more than a decade at this point. And it's been tremendously productive and tremendously fun and a wonderful learning experience for me. And I appreciate the opportunity to come and talk with y'all about it today. I will stop sharing my screen.
Amazing, Courtney. What people don't even realize is that there is a bunch of boxes in my office that are full of these records from Courtney that she retrieved and photocopied, and we scratched the surface. You know, she's a lot of the things that she has right here. We have about, I want to say, about 65 papers on these topics, Courtney, together. If I remember, maybe even more, and we
It's
still have like another 60 that we can easily write
That
about a
is
lot of this stuff.
absolutely correct, sir.
So we have, there was of course, for Susan, there was a pituitary transplant. He was using fat already, Susan, back then, for traumatic brain and stuff like that. He knew there was something special about fat. He didn't know there were mesenchymal stem cells there. He was, as Courtney said, mapping the brain. He talked about Cushing's disease, and we found some new, Mimi, was a Mimi the name of the patient, or Mini? I'm trying to remember,
Mini?
we,
Oh,
yeah.
Mini G, yes.
Mini G, yes, Mini G. So it was absolutely, we found some extraordinary things, obviously, in the archive. So let's open it up for questions. Go ahead, take it away. Who's got questions right here? I think Paola was mentioning something. Dr. Suarez, meet. Go ahead.
Hi, Dr. Pendleton. Thank you very much for an amazing talk. I really enjoyed it. You really showed how Dr. Cushing paved the way for a lot of things that we do nowadays. And for me, I put a comment on how he did the follow-up on his patients via letters is kind of the way that we're doing right now after COVID started, right? Like with the virtual visits. I do have one question. I wanted to ask if you know how Dr. Cushing was personally, if he was like, how was his temper like?
So there are two stories that I think really sum that up. One is he was operating in Baltimore, I believe, when he received news that his son had died. His son died in a car accident in some interesting circumstances. And Cushing sort of took the news and continued on operating. So he was a little bit emotionally distant in the operating room. He had a terrible temper in that he fought with a number of his trainees, most famously Walter Dandy. It's really why we have the double ANS and the CNS. One is the Cushing Society, one was the Dandy Society, and the two did not mix at the time. But one of my favorite stories about Cushing is that one of the Yale Archive collections is his notes from when he was teaching students. And there's this series of notes, lecture notes about, I forget what pathology he was describing, but he brought this female patient in and, was going, pimping the medical students on, what could this be? What questions do you ask? And one of the students asked, well, do you have any relations with dogs? Do you have any family members with dogs? And being off color as usual, somebody in the audience said, well, what kind of relations? And the woman cries and runs out of the room. And Cushing notes that he took this opportunity to teach his students that they need to be sensitive to other people's feelings, which is very much out of character based on everything else I've ever read about him. And I just really love that anecdote because he really does hit the nail on the head that, as surgeons and physicians, it's necessary to be considerate of other people's feelings, and that what we think is funny can be very hurtful. And I think that really speaks to some of his inner character.
I think that maybe the other way to think about it, he was a complex character. I think that a movie about someone like that, nowadays there's nothing is black and white. If you see the latest way that the stories are portrayed is complexity. He was a complex character in the sense that you can see in those cases that Courtney presented, he would advocate, he would fight, he would do things that no one else was willing to do, like keeping them alive, doing CPR, doing respirations, and all this kind of stuff for hours and days. And he was an advocate, but on the other hand, he was also very tough with his disciples, and of course the relationship with Walter Dandy was historic. And Walter Dandy, remember, most people don't realize Walter Dandy was a medical student when he was working with Dr. Cushing in the laboratory. When Dr. Cushing left Hopkins in 1912, Dr. Dandy was barely about to graduate from medical school, and they tapped him to then continue the tradition of neurological surgery at the Johns Hopkins, and of course, Cushing goes on to the Brigham, and it was known that Dandy was a very skilled surgeon, but he was, two generations below. I mean, already this is a young man finishing medical school, and Cushing is already, the professor. Was called the professor at the time at the Harvard Medical School, and they you have a very strong relationship, and that's the way he was, with his disciples, with the people around, and then he would have a certain way of being with the patients. You can see in the communications that Courtney has. It's another beautiful paper where he writes letters to his patients, and the kindness that he showed to his patients. I don't think we saw the same kindness to his trainees, Courtney. I think that may be another way of interpreting this. I don't remember him doing those kind of letters to his trainees or the people around him as he did towards his patients.
I'm correct. We don't have a lot of those letters in the surgical records, unfortunately, but a couple of Walter Dandy's operative reports, Cushing has written scathing marginal notes. So there's certainly documentation of being very hard on his trainees. He produced excellent trainees, but it was a challenging process, I think, to train under Dr. Cushing.
Another question. I had Ricardo, you have your hand up. Go ahead, and then Gaetano.
First of all, thank you very much for the presentation. Very interesting stories. And it's I was thinking jokingly while you were talking, thinking, oh, someone in this day and age did what he did back then. It wouldn't last a day with a license. How regulations nowadays are so tight, how it takes so long to take something from the bench to the patient, and how back then, because everything was so novel, no one knew what to do, it was easier to try it out in a patient, how to experiment, like you mentioned. And my question to you is, as someone that always is driven by the work of Dr. Cushing, as most of neurosurgeons, but also as a modern neurosurgeon that knows how hard it is to bring something new to the patient and to try something new. What's your position in the regulations on nowadays, how hard it is to, or how tight it is to bring novel things and novel practices, knowing where we come from with Cushing?
That is an excellent question. Thank you. I think it's a complicated question because we've seen, within people's living memories, what happens when there are not regulations about informed consent. There's the prison experiments in Guatemalan prisons. There's the Tuskegee syphilis experiment. We've proven, I think, as a community at large, that regulations are necessary because otherwise very, very terrible things have been done. But I think the pendulum has swung maybe a little bit too far, in that we've created so many protections and so many layers of protection and bureaucracy that it becomes burdensome to even try to bring innovation to the table. And I'm hopeful that, as time moves forward, there's a happy medium between protecting the patients and the research subjects who need protecting, and protecting future patients who need innovative treatments. And I'm curious to see what the future holds, particularly as, we've seen what happens when the global scientific community puts its heads together to bring a vaccine to the table in a short period of time. And I'm hopeful that may help push the pendulum a little bit more towards the midline.
Thank you.
Beautiful. Thank you, Ricardo. Gaetano, one last question, because I know we're running a little bit behind. Go ahead, Gaetano.
Yes, sir. Just a quick question. Thank you so much for the great talk, Dr. Pendleton. Just out of curiosity, so since many times the surgeries didn't have very good outcomes, let's put it that way, do you see any letters from disgruntled patients or family members that wrote to him, since the conception of doctors back then was very different, much more authoritative? Thank you.
Thank you. So very few disgruntled patient letters. Now, Cushing was known to play a little fast and loose with his records. He brought things from Hopkins to Yale, brought things from Hopkins to Harvard, things from Harvard to Yale, and things sort of intermixed, and various records have disappeared for a variety of reasons. So it may be that the disgruntled letters simply weren't preserved with the rest of the charts. But there are some patients who keep writing, you know, I have this headache, there's no medication, you know, why don't I feel better? But I think just philosophically, the belief of most of his patients seems to be that, you know, he did his best. And there's a lot more acceptance of that. And I think that's sort of a societal transition at large over the years in terms of how physicians were viewed then compared to now. I don't know that patients would have written truly disgruntled letters, but certainly there aren't any really disgruntled letters in the chart, except the young woman who wanted a portrait of Dr. Cushing. She was very upset that he would not send that.
But the other thing I tended to realize is that at that time, very few people, you know, wanted to operate on the brain. Remember, if you look at Mayo Clinic, Adson, alrighty, he didn't want to be a brain surgeon. They basically appointed him to be the brain surgeon. So people were not into this field, and the outcomes were almost 100% mortality, you know, at the turn of the century. So Cushing was known to bring the mortality down to a way that people realized we can actually do this type of surgery. Yes, patients are going to die, but he shows very systematically that patients can actually be operated on. And I think that that's probably, in addition to all these things that Courtney just mentioned right now, that's probably one of his greatest contribution, that he made it possible for people. But he also, there was some other papers that Courtney and I wrote where he interacts with Pio del Rio Ortega, who was a disciple of Santiago Ramón y Cajal. They began the World Health Organization histological description of tumors in the brain and stuff like that. So he was clearly going around and trying to understand, and he was very multidisciplinary as well. So quite remarkable, actually.
That perception persisted when I was in medical school in the 80s, when you would meet these guys who were sort of giants in the field of neurosurgery. So many of them did not intend or start out to be neurosurgeons. If you would listen to their stories in the 30s and 40s, many of them would join the army during the war, and they would go and they would say, well, the officers looked at my record and said, oh, you did a month of neurosurgery. Good, we need a neurosurgeon, you're the neurosurgeon. But most of, because of lots of things, as you said, the outcome, the state of the field, the outcome of the patients, many of the real giants that were even practicing when I was in medical school did not choose this field as a passion. They sort of ended up there because of circumstances. It wasn't the most popular choice.
Yeah. So good. Well, listen, Courtney, thank you. What a beautiful presentation. Oh, one last question. Last comment for Dr. Vargas, Gabriel from Colombia, from Bucaramanga, Courtney. Go ahead, Gabriel.
Yes. Okay, then thank you very much for this amazing. I think we can pass the whole morning trying to ask questions of many things here. Just curious for that mapping brain. How is described that? How he discovered that? During awake patients, or how was the anesthesia at that time? It's mentioned in the document, something mentioned that how was the anesthesia? What was the kind of anesthesia at that time?
So anesthesia was very rudimentary. Patients either received ether or chloroform or both. And quite frequently, the patients would wake up during the surgery because they had miscalculated the dose, and sometimes patients didn't wake up or woke up very slowly because they had miscalculated the dose. So no paralytics were used, which is part of why mapping the motor cortex was a accessible thing for him. The equipment he used for it was very, very rudimentary. Lots of current spread, really not a lot of opportunity for fine control of what areas of the cortex you were stimulating. And I don't know that he really understood the idea that things are spreading throughout the cortex. I think he suspected it because he struggled to find the leg area, but he'd comment that he was sort of near the leg area, and you see in his pictures, like he wasn't actually over the intrahemispheric fissure. So he was obviously getting some cortical spread. And I think he suspected that. And then he knew it wasn't his forte. So he sort of passed it off to Penfield and other folks and focused his attentions on the pituitary and other brain tumors.
But the stimulator that they used back then, I think at one point we got a picture, one of our papers was a very large machine
Oh,
that they
yeah.
had in the operating room. And it was like, we got a picture of it in one of our papers, actually. It was quite impressive. And one of the things that the Courtney actually beautifully, and the reason why this was a paper that we published in cerebral cortex, which is a high impact paper. We've got papers published in Nature, cerebral cortex, and a lot of really, really high end journals. This one particularly is because he was doing subcortical white matter stimulation. We all thought that it was, Dr. Mitch Berger, who had begun to do this with Ojaman. It turns out that we discovered in that particular records that Courtney pulled out that he was doing already deep white matter stimulation at the turn of the century in the early 1900s. And at the time, remember, the surgeon also served as anesthesiologist many times. This is how Harvey Cushing began the anesthesia record. That was Harvey Cushing's creation as a medical student at Harvard when he was at the Mass General doing some rotations, and then eventually when he did his internship there. If you look at the history of anesthesia, the anesthesia record is attributed to Harvey Cushing as well. So tremendous, in fact, so good.
The anesthesia and the monitoring of
Yes.
anesthesia during surgery also is attributed to Cushing.
Amazing. Well, we look forward, Courtney. Actually, Dr. Vargas is going to be giving us a talk also the history of the Hakim brothers because of all the hydrocephalus. There's a lot of history in our countries in Latin America also,
Yes.
with neurosurgery and stuff, and it's important. And I've been thinking about, we ignore the country. You guys, I think not a lot of people realize that there were trephidations already being done in our cultures, 1,000 years prior to brain surgery. And I think it's important that we begin to understand some of these contributions. So we're looking forward to your talk, Gabriel. So thank you, Courtney. Wonderful talk. Amazing once again. Beautiful
Thank you
work.
very much, sir.
And I know you mentioned a few papers that we need to finish. So
yes,
we're going to get on it.
We will be in touch, sir.
They'll be interested from fellows here.
Yes. Thank you very much. I appreciate
Wonderful. Have a great day, everybody.
Thank you.
A great week.
Amazing.
Take care. Bye-bye. Bye.